Welcome everyone to the EKG case for the week of January 8th, 2012. We've got a nice, short, and kind of a neat case that I saw just recently. It was a 69-year-old man that presented with altered mental status. Now, some of you may be thinking, what can possibly be interesting or neat about a 69-year-old man with altered mental status, right? Just go ahead and get the CBC, the Chem 50, the PT, PTT, even though he's got no liver problems or heparin, he's got to get a urinalysis, CTLP, start some antibiotics. Just go ahead and put in the white card for admitting this patient to the hospital, right? The differential diagnosis here probably is about 50 to 100 entities long. Just about anything can produce altered mental status in a 69-year-old. So where do you start? Well, I suggest you start with an EKG, all right? And this is a really neat case because here the EKG actually takes that differential diagnosis and drops it down to one thing. Pretty amazing. So take a look at this 12-lead EKG. Now, there's a couple of things that you notice. It's sinus bradycardia. The rate's about 50, 55 or so. Not a big deal. There's a first-degree AV block, which is very common in a 69-year-old man. As we get older, our PR interval gradually increases. So first-degree AV block is fairly common in elderly patients. So first-degree AV block, sinus bradycardia. You'll also notice that there's a leftward axis, and that's simply due to the fact that the patient has LVH. He's got an R wave and AVL greater than 11 millimeters. So I'm not telling you anything really groundbreaking, but what I want to focus here on, just like we did a couple weeks ago, is take a look at the intervals once again. I think the intervals oftentimes get ignored, and I want to really focus your attention on intervals with a handful of these EKG cases, including this week's case. So we talked about the first degree AV block already, and the QRS interval looks pretty good. But what do you make of the QT interval? If you take a look at that QT interval, you notice something a little unusual. Now, we talked about long QT a couple of weeks ago. We talked about a simple way of estimating whether a patient's QT is too long or not, is you take the halfway distance between two QRS complexes. So halfway here is right around here, and if the T wave ends beyond the halfway point, then that's considered a long QT. In this case, the T wave ends before the halfway point, so that's not a long QT, but I think what you might notice, hopefully, is that the QT interval is actually relatively short. That's a really short QT interval. In fact, the T wave starts immediately after the QRS complex. There's not even time for an ST segment. It just goes QRS right into the T wave. There's no ST segment. This is a relatively short QT interval. And in fact, I'll give you the EKG machine's interpretation up here. You'll notice the QT interval is 340. The QTC, the corrected QT, is 330 milliseconds. When was the last time you saw QTC that was 330 milliseconds? That's really short. So, what's the differential diagnosis for a short QT? Well, it turns out it's very simple. There's only a few things. There's a congenital short QT syndrome. I know you've heard of congenital long QT. It turns out there's a congenital short QT syndrome as well. It's very rare, so I'm not going to harp on that, but it generally occurs in young kids. It is a genetic abnormality that precipitates or predisposes to VTAC, VFib cardiac arrest, but again, it's very, very uncommon. Second thing in that differential is digoxin toxicity, relatively uncommon also, because not that many people are on dig anymore, and chances are if somebody's dig toxic, you're going to see some other type of abnormalities, maybe PAT with variable block or very slow regular atrial fibrillation. Short QT all by itself is not that common, all by itself that is, for dig toxicity. But in this case, this 69-year-old with altered mental status has the third thing in that differential. It's very simple. It is nothing more than hypercalcemia. Hypercalcemia can produce a short QT and is probably one of the more common causes of a short QT. In this particular case, the patient had a calcium level of 16 milligrams per deciliter, and as you recall, normal is only 9 to 10, maybe as high as 10.5 milligrams per deciliter. So when you see that short QT, suddenly that differential for altered mental status narrows very quickly to hypercalcemia. This patient needs to be treated very, very quickly with IV fluids and some of the other things that you think about for hypercalcemia. But from the emergency department standpoint, first thing you're going to do is fluids, fluids, fluids. I learned back in residency that everybody with hypercalcemia is by definition dehydrated. They need a lot of fluids. Here's another case, 35-year-old woman who presented with a mental status change. She came in very agitated, and once again, the abnormality that hopefully jumps out at you, even if you're using the EKG machine's interpretation, is she's got a very short QT. Look at that QT. It's 278 milliseconds. The QTC is 374. We'll blow up a couple of leads, and you really appreciate that there's a very, very short QT interval in a bunch of these leads as well. So very short QT. We got a quick calcium level on her. In fact, just started treating her with IV fluids, and her calcium came back 17 milligrams per deciliter. Turns out she had sarcoid. So just a quick, nice little pearl. When you see a short QT syndrome, your differential is very simple. Think short QT equals hypercalcemia. Those patients need to be given IV fluids early, and that differential can be narrowed very, very quickly. All right? So, hope that was helpful to you, and I will talk to you next week. Take care, everyone.